Are any of you using fusion imaging? Is anybody doing that yet, or are you just using conventional ultrasound? Anybody doing fusion? Okay, we'll start from the beginning, explain to you what it is. I am a musculoskeletal radiologist, but I specialize in the spine. I do lots of work in the spine, and I would guess that about 2/3 of my work now is dealing with people with back pain and nerve root pain. Since I started in 1984, a long time ago, I've done a lot of injections using fluoroscopic guidance or CT guidance. So when fusion became available, we realized it was theoretically possible to avoid radiation completely. And so I want to show you how we're doing that. And what we're going to do after I show you some cases and some material, how it's done, is then we're going to show you as an example of how we set up the fusion, because it's really only when you see it in real time do you realize how stunning it is and how much easier it makes spine injections. So the sort of things we do in the spine is we inject facet joints. We might put local anesthetic in, steroids, we might use cryotherapy, we might use RF, radio frequency, to heat them, to heat the nerves, to do a branch block. There are a lot of techniques we do around the facet joints. And so to do that, we need to place the needle adjacent to and inside the facet joint. And the traditional way is fluoroscopy, but we can use CT. We also do root blocks where we put anesthetic around a nerve root where someone has sciatica, sometimes to make a diagnosis. Perhaps they have 2, 3 levels that might be compressed, and the surgeon is saying, I want to operate, but I don't know which nerve. But quite often we're doing it as a therapeutic measure because we can alleviate the symptoms for long enough for the patient to get better spontaneously, because most do. So by doing that, we save people from operations. And we may do epidural injections and put needles into the epidural space and put drugs in when we're trying to treat lots of nerve roots. We're not sure which it is, and we're giving palliation when somebody has acute sciatica. And then finally, we might want to implant stimulating devices, TENS machines, which are implanted and we can place wires. That's the more complex end. My old way, the technique I used for many years to do facet injections, and I know that in 2016 I did 157 of these because I've done a research project where we looked at that work, and then we've looked at the work we've done with fusion afterwards to compare them. Placing a 21 gauge needle, we'll put some local anesthetic into the joint and some steroid, usually a particulate steroid like triamcinolone acetate. I actually only inject one level at a time because I want to know where the pain's coming from. If I injected 6 joints and the patient says, it's wonderful, for 12 hours I had no pain and now it's come back, which joint was it? And if I want to do an RF radio frequency denervation, which one? So I always start with one joint until I find the right joint, and sometimes patients will come back 2 or 3 times. Usually, it's where they point. I say, one finger, point to the pain, and they say, there, mark that, look on the fusion imaging, you can work out which joint it is and which one's affected. And that works about 90% of the time. So I call it the digital technique. I use my digit, and we point to it. All the patients I treat, I see them as an outpatient beforehand. I treat them, I do the investigations, and I then follow up. We give them pain diaries to complete, we contact them electronically, we bring them back into the clinic to talk to them. So we deal with the consequences. So we're not just a radiologist receiving a piece of paper saying, do a facet joint injection. Yes, I will do the facet joint injection. Done. End of patient. I don't do that. I look after the patient from the beginning. I try and resolve what the problems are. There is a debate as to whether we should put the drugs inside the joint or around the joint. And there's now enough world literature to say it doesn't matter. Both work equally well. So this is great. As a radiologist, if you miss the joint, it works just as well. As long as you're next to the joint, that's the key thing. You must be at the joint, and you use a small amount. If you put 15 mils of bupivacaine, you're going to anesthetize everything. All the nerve roots, all the joints, all the medial branches. You really have no diagnostic result. Worse still, their leg won't work for about 12 hours afterwards. So they can't leave the couch. They won't walk home. They need a wheelchair and they need to lie in a bed. So we use small doses, small quantities, maximum of 1 milliliter and about half a milliliter of triamcinolone. And if you use more than that, then you're becoming less precise. So this was the technique. We used to place the needle in posteriorly, going down to the joint, technique taught to me by Alain Chavreau in Paris many years ago, and make sure it's going in or around the joint. If you're going to do a root block, then you want to place the needle next to the nerve root. Bring it down to where the nerve root is, not in the nerve, next to the nerve. And that actually is where the precision of this technique helps, because I'm now much more confident that I'm deliberately missing the nerve. When I did fluoroscopic guidance and CT guidance, sometimes I would hit the nerve, and then the patient tells you with a very loud noise, it hurts. If you're careful, you don't damage it, but it's not pleasant for you or the patient particularly. So that was how we placed it. We placed it in the neural foramen at the back, at the superior corner of the foramen, to make sure that we're near the nerve but not inside it. And then we'd inject contrast agent to outline the nerve root to see that we were in place and that we weren't entering into a vessel. CT technique, very similar, bringing the needle down. This is a nerve root block using CT, and we're placing some contrast agent to make sure that it's actually in the right place and not entering other structures. We could also inject sacroiliac joints. Now this is a little more difficult because the sacroiliac joint, if you look at those slices, it's a different shape. At the top it goes that direction, and in the middle it goes this direction, and lower down it's a different direction altogether. So it is a very difficult technique. And these are some examples of cases done in our hospital where we missed. The needle was meant to be in the joint. The radiologist thought it was in the joint. 2 of them are mine and 2 of them are other doctors, and all of them just missed the joint. CT is probably better than fluoroscopy because you can get into the joint more easily, but the drawback is that you have to be truly in the axial plane. It's no good if you tilt down or up. You have to be going in the axial plane to get in. And that can sometimes make it more difficult. And of course, there's more radiation to the patient. And if you're standing next to the patient, you can withdraw into the control room, take a slice, come back. But it prolongs the procedure. And most of us will stand with a lead apron and stand back from the CT. But so we all get radiation involved in that. So this is our solution. This is Gina doing an ankle, which she'll talk about later on today. And this is the setup. And here we have the magnet. That's got a small magnetic field. It has a label on saying warning about pacemakers because it's a magnet. But I've actually talked to the cardiologist, and this isn't even near 1/100th of the magnetic field that would affect a pacemaker. So I think that is GE being very careful, and we don't worry too much about it. So I'm probably not meant to say that, but GE will tell you, worry about pacemakers. I don't. So this has got a mild magnetic field around this area. These probes have within them, this one I'm going to use, has a sensor built into it, but some of the older probes have these separate sensors which clip onto the side. So we have the sensors like this, which are little clips, and that goes on the end of the probe, and these little sensors clip onto the side, and they detect where the probe is. It's slightly inconvenient to have the extra wires, but not really. I sort of forgot that it's sort of there usually. And I don't use that now because I've now got the new machine, which has got the probe already with the sensors built into it, so you don't have to think anymore. It makes it a lot easier. So as I'm moving the probe around, the machine knows where the probe is. So we import the data. We import the MR or the CT, you can have either, into the machine, just electronically as DICOM. And these are not special MRs or special CTs. They're just the ordinary examination that the patient has always had. I never see a spine patient without an MR scan. So we always have the MR. If they do have a pacemaker, we may have a CT. Once we've imported the image, then the first thing we have to do is line it up. So we say, right, we're going to look at the coronal plane, in this case, for the ankle, and we'll say, right, that's the coronal plane, so we'll rotate the MR data set, so we've got the coronal, and you press some of the buttons on here to make that work. I'll show you later. And then you line up the ultrasound and say, I'll scan in exactly the same position. And the first 20 seconds, perhaps, you spend thinking, is my probe lined up in the same way as the MR CT? Okay, so as soon as you're happy it is, and it's usually just a little rotation of the wrist, get the triangle, you think, right, that's correct, you press one button to lock the plane. Now the planes are locked. Whenever I move the ultrasound probe, the ultrasound image will change, obviously, because I'm looking at a different angle, but the MR will change into the same plane. But we haven't fully registered, because the MR might be up there and the ultrasound down here. So we then have to find 2 points, exactly the same anatomical position on the 2 images, that we can co-register. So I have to find, and in this case, you could, for example, look here at the edge of the bone here, okay? And on the ultrasound, you can look at the edge of the bone there, and you can click on them, and you click on the 2 points that you think are the same, and we'll show you in a practical demonstration in a moment. Click, click, done. That's it. So the fusion is lock plane, find 1 point on each picture which is the same, click on it, and the fusion is connected. Then you check. Now this is important if you're going to put needles in, because you want to be sure that the 2 planes are exactly the same. So look around, look at other subjects, rotate to a different angle, make sure that the same structures appear on the 2. If in doubt, you can re-register. You can find another point, click again and click again. Usually you don't need to. Usually it's locked at that point and you're pretty accurate in that stage. Now the research done to date has all been done on the liver and the prostate, and there is some data that says that in the liver you can accurately lock to within 8 millimeters of your target. So that's quite big, that's almost a centimeter. But I think that's because people breathe and their liver moves up and down, and the liver's a big squidgy thing. Spines, bones, ankles aren't, they're solid. My instinct, having done many, many of these procedures, is that I'm probably accurate to about 2 millimeters in terms of locking. Now I'm happy with that, because I want the drugs to be within 1 centimeter. That's it. So 2 millimeters is fine. And actually, having done lots of CT and fluoro, I think I'm better with this in terms of needle place than I am with the fluoro and CT. But I can't give you much science behind that, because it's very difficult. Strangely, the ethics committee in Oxford will not allow us to dissect the patient after we place the needle in. So it's difficult to prove that. Okay, so there's the magnet, there are the sensors. This is the sort of imaging, that's a wrist, that's an ankle. We're fusing CT and ultrasound here. But this is the spine, and this is what we're going to talk about now. So you'll see on the top images that the axial view is showing the spinous process of the vertebral body, and it casts a shadow. So there is the bone casting this shadow behind it. That's the same structure as here. Inside the green line is where the ultrasound is appearing. So we can see where the facet joints are on the MR, we can see where the nerve root is on the MR, and we have to presume that it's in that location on the ultrasound, because we can't directly see them. We're seeing muscles, we're seeing skin, we're seeing bone surfaces, but when you get down to this sort of depth, even with really good machines like these, you're still not resolving nerve roots. We can't see them. But we can see the structures around, so we feel confident that we're there. We're going to be near to that nerve root, or near to that facet. As you rotate the probe, of course, the MR is reconstructed, and they may be 3 millimeter thick slices. So the image is rather bad quality. But for guidance, it doesn't matter. That's never been an issue for me. I've always found that those reconstructed images are fine. I can see those facet joints, I can see those nerve roots, I can see the facet joint here, and so I know that the nerve root is going to be down here, and I can choose that as a targeting point from there. And again, we'll show you a real-time example, because it's much easier to see on the moving image. Here's an SI joint, for example, and this is the sort of fusion where you move around and you get both. And you can see the joint changes in its shape and angle. Now, the first time I did a sacroiliac joint injection using fusion, I placed the needle and it went straight into the joint without hitting the sides. First time in my career I've ever done that. Every other sacroiliac joint injection on fluoro or CT, now there's the bone, got to move a bit, move a bit. It's gone in, that's it, it's fallen into the hole. With fusion, you don't touch the sides. And it's quite a surprise. You think, whoa, that's gone, oh, it must be in, that's it. The result of which is much quicker. We've done a study where we looked at the technique of fluoroscopic guidance, me doing it, and we've looked at the time it took me to do the procedure, and we've looked at the time it takes me to do the facet joint injections. We're presenting it tomorrow morning as a paper. And on average, a fusion-guided facet joint injection or a fusion-guided nerve root block takes 60% of the time of a fluoroscopic-guided technique. So where's the extra time? Because lying on the bed, setting up the machinery, it's the same as putting the fluoro on and checking where things are or doing your preliminary views on the CT. The extra time is fiddling with the needle. That's the extra time. With the fusion, needle there, done, finished. With the fluoro, it's hang on, more local anesthetic, I'm sorry it's hurting, we're going to move the needle. Yeah, okay, that's now in place. With the CT, you place, you scan, no, I'm short, I've got to come back, I've got to go down again, I've got to angle this, right, do it again, okay, yeah, okay, maybe that'll be enough, that's all right. So the big difference is the needle skin to positioning is much quicker, and it saves about 30% of the time, maybe 40%. So that's an advantage to the patient, and less needle puncturing, which is a help. Now it gets better, because what we can do is we've now guided with fusion, we know things are, but what we can now do is we can put a tracker in the needle. Where is the needle? It's around there somewhere. Have you got the needle? Ah, Brent's on the side. I just wasn't seeing that, thank you. Here's the needle. So this device has also got the radio transmitter in it, so it's sending signals to the computer and saying where it is. So in here, and we cover this with a sterile cover. It's a big long plastic tube, and this part is non-sterile. The needle is sterile, but this little bit of wire is non-sterile. But that comes in a plastic cover, and then this is the sterile bit, and so we then have a very delicate bit, and if I've drunk too much tea or coffee, my hands shake, and it's not good. So that's got to go in like that. Now it locks into place, so this needle has a wire down the center. Now the hole down the center doesn't have a hole at the end, it's just inside the needle. So we now have a needle which we can see on the screen, and we'll show that as well. And it tells us where it is and where it's going to go. That's really clever, because what now happens is we can predict where the needle's going to go. We can use the ultrasound on the MR or the CT to find out if there's a piece of bone in the way. So we can predict our route. We can position this. So, no, there's a bit of bone in the way. I'll move it over there. Right, that's it. Now I'll put the needle in. And then the needle just tracks straight down to where you want to go to. And it gives you a color on the screen. So the needle will be green if you're going to hit your target. And you preset the target. You choose the target with a pointer, and you target the position. It's then green if you're going to hit it, brown or blue if it's going one way or the other. It is just like a video game. And when you're doing it, you think, they're paying me a salary to do this, and this is a video game, and it's so easy. That's done. Okay. Then you think, perhaps I ought to make it sound more complicated. This was a really tricky case. It took me a long time to get the needle there, but I think it's okay. It is easy. It actually is really easy when it gets to that stage. Even better, because we are tracking a needle which is being detected, it doesn't matter where the ultrasound probe is, it can be over here. And you don't have to be next to the needle and guiding it. You don't even have to see the needle. You can see the needle on the ultrasound, but I don't bother. I actually use the MR section or the CT section and follow that. It's like having a real-time MR scanner in your hand, because you are looking at MR in real time at the same time as moving the needle, and it makes it very easy. Now, these needles go down to 18 gauge, so they're fairly thick. That actually is an advantage for positioning, because they're not going to bend very much. There is a virtual tracking system, and that is the same setup, but at the end you have a little plastic connector which you can put an ordinary needle into. So you have the same setup, but this is a sterile spinal needle. If you do that, I recommend you use a stiff needle, 19 gauge or bigger. 21 gauge will bend all over the place, and you've no idea where it's going. They're stiffer. It's not as precise, and I've been using it recently because our wire broke. And I think I'm probably accurate to about a centimetre and a half, but it's not as good because the needle can deflect and bend. But it has the huge advantage that you're using thin disposable needles, and it's a little bit quicker and more easy to do in that sense. And so it's my preference to do facet joint injections with that when I'm not quite as precise as I'm for nerve root blocks. Okay, let's move on and talk about what you see on the picture. So here's the needle in place. We've set at a target point, it's there. We can see the needle tip is at N, and it's blue, so I'm not going to hit the target. So I have to move and angle the needle slightly till this goes green here. And we go a little further, we've now got it green. Okay, so here is the needle, green all the way down to the target. See where the target is on the MR? It's next to the nerve root. I put the T, this is my personal choice, just in front of the nerve root because I don't want to hit the nerve root. So I'm going a little bit short of the nerve root. So on here, if you see, there's the nerve root below. I want to be just short of there. And I want the needle to get close to there, but not actually there. A moment or two later, we've moved the needle forward. We've now got the needle close to the target point. That, to me, is near enough, because if I go any further, I'll actually cause pain. And when I put the drugs in, it's going to fill that area, so it's more than enough to deal with the problem. So having got in position, I just disconnect this, and it leaves behind a cannula. So I've now got a cannula in place in the patient. That I can give to my assistant, and they can put it away. I don't need it anymore. And this is now going down to where the nerve root is. There is a theoretical problem. The problem is that if we had that needle half in a blood vessel, half out of the blood vessel, what will happen if I was doing CT or fluoro is that I would inject contrast agent, and on CT, I'll see it surrounding the nerve. CT isn't going to show me if it goes into a tiny vessel pastorally at the same time. So CT is useless for this, doesn't work. Fluoro does, because we'll put the digital subtraction on, do a little DSA run with a roadmap mask, and then we'll see the blood vessel going in, which is what I've always done with fluoro, which is one of the reasons I preferred fluoro in the past. With fusion, can't do that. The problem now is that when I inject this, is this going to go just into the space around the nerve, or am I going to go into a blood vessel? If the blood vessel goes in through the neural foramen and into the corda equina, or higher up into the spinal canal, you could cause infarction of the spinal cord. Now, this has happened, not in the lumbar region, but in the cervical region. People have caused cord infarction, and patients have died on the table. So that's bad. To avoid that, the Koreans suggested, and I agree with this, they suggested put in a test dose of lidocaine. Just 0.2 of a mil, small quantity of lidocaine, little dose of lidocaine, then wait for about 2 minutes. And then say, please move your legs, just move your feet. And if their feet move, you have not injected into the spinal cord or into a vessel, because if it's in a vessel going into the cord, they will get instant paralysis from here downwards for 1 hour. Now, I know this because it happened to me once. I did a cervical injection, put lidocaine in, and the patient said, I can't feel my feet. I can't feel my knees. I can't feel anything, and then he stopped breathing. I phoned the anaesthetist very quickly, and we crash call, intubated, ventilated for 1 hour, recovered. Absolutely no long-term effects. So lidocaine into a vessel going into the spine is scary, but as long as you have a phone and a crash call, it's okay. But if you put triamcinolone acetate in, you've paralyzed the patient, and in the neck, you've probably killed the patient. So it is so rare, we think it's 1 in 500,000. But to avoid that, tiny dose of lidocaine, and I believe that you probably increase your safety. This was written up in South Korea, and they don't have any real hard evidence, nor do I. We're just saying this is probably the best way of doing it. So at the moment, we use the lidocaine test to make sure. This is when we started off. We did a number of patients, which we used with E-track guidance, consecutive patients, and we established it. I've just explained that all to you, so I don't need to go through that again. Did the lidocaine test. And in those patients, 16 out of the 22 who we got follow-up from. I don't know about you, but our patients forget to send the forms back. And it's around about 67, 68% return the forms, and the others don't. Now there's an argument. Those people who didn't return the forms, were they the ones that got better and just forgot about you? Or were they the ones that didn't get better and don't want to speak to you anymore? Interestingly, Gina's done another study, and she's actually looked at this. They contacted all the patients because they had to follow up for different reasons, and there was no difference in the two groups. The outcome were as good and as bad in the groups that didn't send them back and did. So we feel moderately confident that of the 12 that we got replies, 16 we got replies from, 12 of them had substantial improvement over 24 hours, and 13 had lasting improvement at 2 weeks. The increase is probably because the steroids start to work after a few days and they have a better effect. So that's very much what we thought. And tomorrow we're presenting a big study where we've done hundreds of patients, and there's absolutely no difference in outcome between fluoroscopic injection and fusion-guided injection. So there is no difference. That's what I wanted to know. This works just as well in our hands as the other technique. So that's the result of the studies we'll be presenting tomorrow. You're getting a preview of this, and those are all the patients showing statistically absolutely no difference. About 2/3 of them get better with the injection and 2/3 don't. Okay, so what about the accuracy of the patient, the placement? Well, that's the paper I was telling you about with 8 millimeters. I think it's probably 2, but I'm not sure about that, and maybe somebody needs to do some animal research on this to actually work out what the precise placement is. I feel confident, and I'm happy to use it in clinical practice. We do not need, I've told you about the test dose. Do we need special MR sequences? Definitely not. If you wish, and you have time and availability, a volume acquisition will be much prettier. But I don't think it's any better. I think it's just as good as the conventional MR that the patient already has. Do we need special MR positioning? Well, when you lie in an MR scanner, you're lying flat on your back, and when you lie on here, you're lying on your front. So the bones will move a bit. So the solution is really simple. Do the fusion at the level you're going to inject, because the bone doesn't bend. The other bones move up and down a little bit, but when your fusion is set for, say, the L4 vertebrae, if you choose that, that's going to be fine. So in practice, it's had no difference. We don't worry about that. We just fuse at the level where we're going to do the injection. And if we're happy that's fused, the vertebrae 3 or 4 away doesn't matter very much. Now, because it's going to annoy you and me, just for the moment, I'll turn the needle tracking system off. What we've done is press the V Nav button, and that brings up 2 screens. You can load your data set in there, and have we got it loaded? Don't think so. So it's there, is it? It's there already. That's it, the latest data set's there. So we simply press a button that says load, and you can load it from a CD, you can load it from a USB stick, or you can load it from your PAC system, or already installed in the system. Really easy. You just select it and load it. And it's on the CT, it's easy. You just select the single volume acquisition. But on MR, it's usually best to go for the sagittal ones. I find they're more precise. Very often the axials are done as blocks at disc-orientated, and if it is, that just doesn't work because you've got gaps. You can use an axial data set if you've got a complete block on MR, but in general I find the sagittals best. I'm now going to place the probe on her back. Yeah, let's reset it. Yeah, we'll reset all. Yeah, there we go. So what we've got now is an axial data set there. We've got a sagittal view of her spine, so we don't want that. Is that going to come up on the screen?
No, you know what? It's the machine that's connected.
Okay, right. So hopefully you can see that one behind there. That's good. Right, so I'm seeing... They come closer, yes. Come over here and have a look. You'll see better. Yeah. So now what I want to do is I want to turn this to be the same angle. Now, cleverly, GE have said these buttons now, instead of being color flow and power, are rotating pictures because we've got this software running and it tells us what's happening here with this trackable. So if I press the color, it rotates it, and now she's lying on her tummy. Now I want to go around the other way, and I press the power button, and I get this, and I've now turned it around that way. It's gone off, so I'm going to move image. So I press the button that says move image, and I can now move it down there, so I'm roughly in the square where the ultrasound's been, roughly got the spinous processes in the center there. Now, that's the wrong CT slice. I want to be on a different position, so let's try scroll images. So we press scroll image, and the little hand comes up, and I can now scroll this, just as if I was running through the CT. And I've found in practice that it's best to do the spinous processes in the middle. Now, very conveniently, Laura has one spinous process with a little spike on it and a flat one there. And this one actually has got a little notch in the top. So let's have a look on the ultrasound. Now, the CT is not moving. It's locked. I'm going to move the ultrasound. I find the spinous processes. There's one. It's got a flat surface and a spike, just like that one. Let's move down. This one has got a point, and then there's a notch, like a little divot, a notch there, and I think I can see that there. I can zoom that up by turning the zoom button, and can you see there's a little dent there? And I think I'm seeing that dent just there. Now let's go around to the next one and see what that looks like. That looks round. So we can recognize these spinous processes by their shape, and everybody's different. So what I'm going to do now is say, right, I've got this ultrasound probe in a sagittal plane. I can see the tips of the spinous processes, so I'm obviously in the same plane as this. So I'm now going to lock the plane. It says lock plane here. I press the button. Locked. Now those two are locked in plane. They're not quite in the right position, so this is a bit different place to there. But as I move around, both ultrasound and CT move. So let's choose a spot that we can see on both for certain. There's our little notch, just there. So I'm going to point to that and click the right-hand button to lock point. Now, only the ultrasound moves. So can you see the notch appearing there? It's just on the picture there. So we'll lock that. Right, now they've moved, so they're in position, and they're locked together. So now, let's check. Okay, we go down to here. That is, whoop, wait, slow down, there we go. Yeah, it's frozen a bit, there we are. I'm going to move down to there. Yep, and I've got that bit of bone, looks the same as this bit of bone, so I'm happy with that. I'll move up to the spinous process above, and I can see this flat bit here, as well as that. I'm going to rotate through 90 degrees. And now we're seeing the spinous process. So the spinous process is here and here. Now sometimes this looks a bit low or deep. And if I wanted, in fact that's pretty good, and in practice I probably wouldn't change this, but I'll show you how I would do it. I'd say, right, there's the bit of bone for the spinous process, so I'll lock that again, and then I'll take the bone in the same place and lock it. And, yeah. And now we're seeing, can you see how that tilts across? That's that tilted bit going there. Go a bit higher. We're coming off the spinous process, and then we're coming on to the next one. And we've got the two, and it's got that rounded appearance there that has in that location. So that makes me much more confident that I'm fused everything together. You can use this flat plane of the lamina, which I'm seeing here. So I know that must be the facet joint there. So if I was going to do a facet joint injection, I would choose that spot there. So let's imagine we're going to target a nerve root. So there's her nerve root coming out there. It's down at the bottom. It's outside the screen because I want to make the ultrasound a little bit, oh, wrong way. There. Okay, that's got it now in the green area. So that's my nerve root. And if I want to hit that point, I'm going to put a target on. So GPS, I like doing that. Okay, yes. So I bring the GPS screen up. Now, global positioning satellites. As far as I'm concerned, there are no satellites involved in this, but I understand why they use that term. It's a strange term there. So we can do a 2D marker here, and I'm going to take a target there. So my target point is going to be the nerve root. There's the nerve root. I don't want to hit it. I want to go just in front. I put a T, and look, it appears on here. So that is where the nerve root is. Now, I know that that bone's in the way. So if I was to come in from the top there and place my finger there, if I came directly down, I'd hit the bone. So I don't want to be there. I want to be over here somewhere. So I think, right, I need to be over here, and I need to miss this bone, and I want to come in here. So let's use my finger. That's where I would place the needle. So I take my finger away and put a felt tip mark on there. So that's my target point. I put this away. I get my helper to clean the non-sterile jelly off. I wash my hands. I get the drugs ready and check the drugs. We then place lidocaine into the skin just here. Antiseptic, lidocaine, drapes, all of that stuff. Whilst I'm waiting for the lidocaine to work, I then get this probe covered in a plastic cover. If I'm going to use the tracking system, and have we got the tracking running? I might just put the needle in. For nerve roots, I would definitely use the tracking, but for a facet joint, I might not, because I can see the needle going down to the facet joint. I can or may not, depends on the patient. But let's say we're going to do the tracking. So what I do is needle. Now, I'm promising to leave the plastic cover on so I don't give Lara an injection. Okay, so we take the needle this off. We cover this in plastic all the way, so it's all sterile, and I've now got a cover on here. I've got gloves. I've got this covered in plastic up to the needle, which is sterile. I introduce the needle into the skin first, but when it goes in, because it's an 18 gauge, it goes in and it doesn't hurt. The lidocaine is frozen. I say, you'll feel me touching you, and you will feel a little jerk, a sort of funny feeling as it goes through the fascia. And as it goes in, it goes jump like that. And strangely, it doesn't hurt, but the patient goes, ooh, what's that? They jump, it unsets the fusion. You've got to start all over again. So I warned them. I said, don't move, but you're going to feel a funny feeling. It won't hurt. Once it's in place, that's enough. I can now place the probe on. So we've got, she switched the needle tracking on. So if we put the needle there, yeah, let's do the V Nav show needle tip. Right, now we've got the needle. Okay, so you can see now that that was my entry point. So my needle is in there, and I've got the target point. There's the target point on both sets of imaging. I'm going to miss the nerve. Now, if I tilt this way, it's blue, and the green is in the skin higher up. If I tilt that way, okay, thank you, that way, it's all right, it's gone brown. I've gone too far the other way. So at that point, it's green, and my little circular dot is on the target, so I know that's going to work. Now notice my probe is a long way away from there. In fact, I could have the probe here, or I could put the probe here, and it still works just as well and tells me when it's green, when it isn't. So the position of the probe is almost irrelevant to this targeting system. So all I do now is push the needle, and the N that you can see on the skin there goes deep and just ends up where the T is, so you make it match. And it is ever so easy to do this. And as I said, it feels like cheating. And it is very quick, and it's maybe 10 seconds to actually push it down to that position. You stop, you remove the trocar, and you inject the drugs. You take the needle out, and you clean the skin, put a sticking plaster on, and they go home. So it's a very quick procedure. If I was doing a facet joint injection, then I've got three choices. I could use one of these. These are, I don't know what they are in Austria, but in the UK, they're about 60 UK pounds, about 62 euros for that system. So that's quite expensive for a disposable item. But for lumbar blocks, it's worth it, because we're actually talking about a cost to the hospital of about 400 or 500 euros for doing this procedure. So as a percentage, it's not very high. If I'm doing a facet block, I can avoid this completely. We'll switch that off. Okay, and I can put that away somewhere there. Well, thanks very much, great. So if I'm doing a facet block, then my targeting will be different. So we've still got that data set. Right, let's say that's a facet joint we choose. We'll go back to the targeting. We can put a point, and I can do another point. Now you can target more than one. So I could target 2 facet joints and leave the other target there. So you can go for more than one target point, which is very helpful because I'm usually doing both sides. So what I would do there is I'd place that like this, okay, and I'll look at that joint and I'll think, right, I'm coming down there. I'll use my finger and think, right, that's where I want my needle to go in, make a mark on the skin. I go to the other one, I find the target point, I use my finger again, and I can see it distorting, put my fingertip under, maybe a bit there, and I put this marker on the skin vertically above. So I then put 2 local anesthetic injections in. I place 21 gauge spinal needles in to the skin at the same time. So 1, 2, they're sitting up, and I simply put the probe on at that stage, and I can now see my target points, and I can see the needles. And I see the needles more by tissue deflection, and so I just push the needles down till they hit bone, because I know that because I've set up this target, I'm going to hit bone. If I go vertically, I will hit bone. And I know how deep it is. Now, let's say I mistakenly send the needle this direction. There's nothing very important around there, but the needle will go beyond the how many centimeters we've got, and we can measure that, and we've got 4 centimeters roughly. If it goes beyond 4 centimeters, I know I've missed, and I can come back and reposition. So actually, most of the time, for facet joint injections, I use the guidance of the real time of ultrasound and this positioning with just a 21 gauge needle, and I don't worry about the guidance techniques. If you want, though, you can use the other device. Where is it? That's the virtual tracking. You don't see the nerve directly. You see it on the MR, but you don't see it on the ultrasound. You just know it's going to be there because you've got, you know you're within about 2 millimeters. So stop 3 or 4 millimeters short of where you want to go, and that's more than close enough. It's as good as you'll ever get with CT or fluoro. Have you got the virtual tracker anywhere? I just wanted to show them the cable. It's in here, I think. Is that it? There it is. Right, instead of the needle, you plug this one in. And this has got a little black thing at the end. And this has, you cover it in plastic again, it has a little clip, a little plastic clip about that big, sterile. And this has got a little screw thread, and you can fasten a spinal needle into it. And then you have exactly the same device as you have there. And it's called virtual tracker. And the only extra bit of work you have to do is tell them how long the needle is. So the machine says, how long is your needle? And you say, 10 centimeters or 9 or whatever it is. And you can actually pre-program. I've got spinal needle. It's already set in because mine are 9 centimeters long. So it then tells you where the needle is, but it's a virtual tracker. It's assuming where the tip is. It's not detecting it because it's detecting this. Now, you can do that for facet joint injections and use that system. Now, did you notice that Laura was breathing? Hopefully you did. Okay, so as she breathes, this moves slightly. Have a big breath, see what happens. So there's a slight misregistration. You can overcome that because you can use this very same device to actually fasten on her skin, and it then uses this as a registration of the stationary, and it moves the image accordingly, so the computer will compensate. Actually, I don't bother because it takes me a long time to do. But if you want to be more precise, you can use that as a way of stabilizing it. Okay, so in someone maybe who has a bit breathless and they're taking big breaths, it's quite a good way of stopping that breathing artifact. In practice, I've never found that a problem in the spine because the spine doesn't move very much and you're lying in a prone position.